Tarsus Pharmaceuticals Incorporated applies proven science and new technology to revolutionize treatment for patients across several therapeutic categories, starting with eye care. Their lead product, Xdemvy, lotilaner ophthalmic solution 0.25%, is FDA approved in the United States for the treatment of Demodex blepharitis. Learn more at tarsisrx.com.
As much as we've learned about ocular surface disease, there is still so much yet to be discovered. The good news is, this creates a world of opportunity for eye care providers.
The goal of this podcast is to better understand this chronic and complex condition and keep you up to date on the advances being made in its diagnosis and treatment. So let's get to the point. Hello, happy 2026. Welcome to another episode of the To The Point podcast. I'm Jackie Garlich, and I'm joined by my co-host Jessilin Quint. Jessilin, happy New Year, friend.
Happy New Year 2026. Here we come.
Here we come. Yes. We are, kind of going to do something a little different. We did it finished in December with a podcast with just me and you. It was really fun. We're doing it again this time too. And, of course, we're still talking about dry eye. But something that I hear a lot from our colleagues is like, well, there's a lot of dry eye treatments. Prior to 2016, we didn't have a lot of options. And now we have been hit with a ton. And what am I doing? And when and for what patient type am I doing? So that's our plan today, is to kind of talk about that. Yeah, does that sound good?
Yes, I love it. And I think because dry eye is so prevalent, sometimes we do have to meet our patients where they are. And so sometimes I feel like with patients, we're dealing with the bond on a budget approach. Sometimes we're dealing with what will insurance cover approach. And sometimes patients are like, I want everything, that's best for my eyes. And so I think as you and I kind of have these conversations to kind of walk through things we look for, but also just talk very real world, right? Like what do we do when a patient can't afford these, or what is our next option? But it is very widespread and it can be very overwhelming. And so hopefully we can kind of decode some of this.
Yeah, let's decode. Let's start with probably the most talked about one, and the one that everyone associates with dry eye is inflammation and targeting inflammation. So when we're looking at a dry eye patient, what is it that you see clinically about them that makes you think this is a super inflamed patient that I need to quiet?
I mean, obviously, if it's red and hot, right? All those classic things. If it looks very inflamed, obviously, there is probably inflammation that's there. But I guess inflammation at its core is also just a loss of homeostasis, right? So I know that that's why inflammation is so just widespread and kind of all these different facets of dry eye. But staining, is a big one, right? That, even using diagnostics like MMP9 testing, even kind of looking at that tear osmolarity approach. What
Yeah.
else do you look for?
I think corneal staining is huge, certainly conj staining, but also that lid margin erythema, that kind of beefy lid. It's easy to say, I feel like, kind of go right past that and just throw in the fluorescein and look, what's happening with the cornea, but the lid can be so helpful too. I think, it is, as you said, it really is such an inflammatory condition. It's so common. So, seeing it, I think, is we all pretty much got it. Like, that looks like an inflamed eye. We should probably try to quiet that down. And I use MMP9 in my clinic. I think staining, I don't think you have to. There was many years I didn't use MMP9. I do think it's a useful tool, but I think you can certainly practice without that, and simply do the fluorescein dye that you have in your exam room and lissamine green for extra fun. And then, how do we want to treat these patients? Let's start with okay, they're inflamed. What are we doing? Budget? What are there OTC options that we could reach for this patient? What do you think?
I think if I was dealing with inflammation, bond on a budget, all those classic lifestyle changes, right? Like looking at somebody's diet, sleep, stress, environment. If they have a coexisting condition, something systemic related, right? Obviously treating that the best, or rerouting. But sometimes if they're having, maybe an OTC allergy drop, right? Depending on what type of inflammation that we see. And tears and anything we can do to kind of rebuild that homeostasis is definitely helpful. But sometimes when you have just a really inflamed eye, OTC can be a little limiting, but nutraceuticals can, potentially be a big win there. What do
Yeah.
you do for OTC?
Yeah, I mean, that not much, to be honest with you. I mean, depending on how inflamed we're talking, if it's milder, okay, maybe we could, talk about some OTC lubricating drops, certainly nutraceuticals, but there's not speed with that. That certainly takes time. What I still consider to be on a budget is even just a steroid drop, just to do, like a nice week or potentially two, depending on what we're dealing with a steroid to calm them down. That can be done inexpensively. There's generics out there now. So I think, the access to a generic steroid to try to quiet inflammation will move the needle a lot farther and a lot faster for your patient than trying to sort of mess around with some over the counter things. There's certainly the, in office treatment options. So, if you're trying to target inflammation in the office, I'm reaching for like if I'm talking in office treatments, I'm reaching for my IPL a lot. When I've got a lot of inflammation, particularly in that lid margin, is what's really guiding me a lot on whether I think IPL will be beneficial for the patient. I reach for that to target inflammation. Yeah. What about you, Jesselyn? In office things that you're doing?
Yeah, definitely IPL. Maybe sometimes a Rinsada depending on, what I see there potentially. That's kind of another in office. Obviously treating the lid margin, which we'll probably get to is, like with the zest, effects, like, well, that can sometimes be helpful, but purely inflammatory, IPL is huge. And then if I'm thinking long-term inflammation, I'm definitely thinking about our immunomodulators. We have a gamut of those, but sometimes that can be helpful as well.
That's a good call out on the Rinsada. That is really useful. I've been using that a whole lot more recently, and patients patients do like Rinsada. It does. That's the treatment where it has a gentle but high pressure flush that really tries to flush out that upper fornix and lower fornix area to remove any sort of stuff that's kind of getting trapped there, and that tends to be very helpful too. And while that is an out of pocket cost for the patient, that's lower. Certainly, it's no IPL, so that's another
True.
option.
And lower for a practice to bring it in,
Oh, yeah.
getting a Rinsada kit is a much lower price point, which sometimes even the practice and the provider might be balling on a budget a little bit. And sometimes you have to start in steps. So I think it's nice to have options. And sometimes when I'm telling my patients, I do tell them everything I recommend, but then I'm also, if we can't quite get there, we talk about options that might take us a little bit longer, or we might have to kind of do this in a multi-step approach.
Yeah, yeah,
So
definitely. I think a lot of patients, I mean, there are patients that don't do things the first time you talk about it, in office treatment wise for doctors that have in office treatments, but it sort of plants a seed. Like this would be beneficial for us to do. And then if patients say, okay, let's try this or that, I'm totally on board. Yeah, we can try any sort of step up the ladder and see, if anything else is as effective as what I was hoping this in office treatment would be. And if it is, great, right? That's always our goal, I think, to do the least to a patient to make them better. And yeah, it's nice to have these in office things, but I think walking up that treatment ladder is a nice starting point.
I like that you said plant the seed because that is very true. Sometimes people have to warm up to it, save up for it, or they're just not
Yeah.
ready. So
Hmm.
I think, and I want us as eye care providers that if somebody says no, to like still bring it up down the road. You planted the seed, but still revisit it, document it, exactly what you recommended in your chart notes. But I know sometimes when I talk to colleagues, if they get that like rejection, then they're afraid to talk about it again the next time. But don't be afraid. Keep recommending that. Sometimes repetition is key to for patients to hear it, for them to want to be able to move forward with those different treatment options.
Yeah. And I do think I'm sure you're the same. It's very, very no pressure. This is just what I think would help and move the needle more for the patient. But I've had many patients on my schedule that say, I think I'm ready for X treatment that we talked about maybe even last year. So sometimes it's not this immediate, oh, sure, I want this treatment now. They need to, build into it a little bit for all the reasons you mentioned.
Definitely. When it comes to an immunomodulator, what governs yours? Because we have several different concentrations of cyclosporin, we have lifitegrast, We have, Viva, you know, which is a different version of cyclosporin and a different, kind of vehicle. I think for me, as much as I do have some nuances, sometimes for immunomodulators, it kinda comes down to access. Like, sometimes I feel like for that, unfortunately, that, at least in my part of the world, has been a little bit of a, you know, you have to kinda play that game, and sometimes that can dictate that area a little bit more than other types of dry eye treatments.
Yeah, I totally agree. I use them all, honestly. I will reach, for one, and if it's not covered, I'm reaching for another. And unfortunately, that is what happens. And I don't know if this is true in your clinic who does your prior authorizations, but if there's a problem, I will hear it. And I've had the person who does my prior authorization say, "Can you please stop writing X because it keeps not getting covered and it keeps, you keep needing the step therapy of this to be able to write that." I'm like, "Oh, sure, okay, I don't know." Like I'm just, I think I think they are all good and they all have their uniqueness about them that can make it better for one patient than it is for another. But I agree with you, Jesselyn. This is the age we're in. It comes down to access most of the time. Yeah.
So that's inflammation. What about evaporation? So what are some, like, big clinical signs or even, like, patient symptoms that kinda hone you in that, boom, this is more evaporative?
Yeah, my evaporative people, this is more looking at tear breakup time. I'm also looking at the meibomian gland, so just doing a very simple press with my thumb to determine what sort of obstruction, if any, that we have present. And then symptoms for a patient, a lot of times these patients complain about things later in the day or after prolonged screen time. Sometimes you'll see inferior, staining as a result of that. Yeah, this one I think is pretty straightforward. It's so common too. We have learned the statistic in any number of lectures that you attend or that you and I have given together, the how common it is to have some meibomian gland dysfunction there. So easy to address, simply looking at the patient in the slit lamp and pressing on some meibomian glands. Even if you don't look at a tear breakup time, which sometimes can have some variability with it, looking at the meibomian glands will really guide you on whether or not there's some evaporative issue there.
Definitely. I think symptoms too, you know, just really honing in, that's one big thing. So if you have a patient that has evaporative, and what are, like, your OTC kinda go-tos?
I try to do a more, um, well, my OTC ones are, I like to do a more lipid-based drop if possible. Certainly, any sort of preservative-free over the counter. If there is not inflammation in the lid itself, then I will recommend a warm compress with some gentle massage. See if the patient at home can, potentially work out some of this thicker meibum after using heat. If that lid is inflamed, I do not, choose that route. I won't have them put, heat right on it. But those are sort of my over the counters. Is can we sort of supplement with a lipid based drop and see if we get some improvement there? What about you? Are you reaching for something else over the counter?
No, that, and then usually, like, a nutraceutical, you know, to kinda add that in, and having the diet discussion for sure. A lot of times, I mean, sometimes you do have to meet your patient where they're at, but warm compresses, hot compresses, you did an awesome study that showed how, you know, how compliant our patients with those, like, what was it, at 18%, I think?
Yeah, I think it was 16. I'm trying to
Yeah,
remember what it
I
was, but
think
it's low.
maybe it was 16. But, you know, if you look at the studies too that show, like, the temperature that's needed to heat those oils, it's like 107 degrees, 104, 107, and so when I think about, like, a warm compress, hot compress, is that really getting that? Maybe not, but sometimes it's, like, the best option that we have, but I think just also explaining it to patients that way, sometimes it's a fine edge to where if you hype it up so much, then they might think that that is equivalent to maybe some other options, and but you do have to meet your patient where you're at.
Yeah.
Pharma-wise, I feel like Mibo is, like, my
Oh,
big, yeah, see
yeah.
evaporative, boom.
Yeah, yeah, it's evaporative. Mibo can be very helpful. Mibo is the easiest lift. It feels good. Some of our immunomodulators, many of them have some sort of side effect with it that's sometimes, just very minimally unpleasant to a patient, sometimes more significant. So MIBO is so easy to sort of reach for. Yeah, I also use MIBO a lot. But one word on that in-office compress, or sorry, the at-home compress, it is sort of like a good, better, best situation. And I usually tell patients that, like, I want you to try these at-home things. I have things in the office that I can do to unblock those glands. Sometimes the con of that is that's out of pocket for you. So I'm going to tell you about some at-home things, but if that doesn't move the needle, and to be honest, a lot of times it doesn't. For the compliance issue, the issue with heat that you've already discussed. But that's where I think the planting of the seed is helpful to say, if this isn't working for you, I've got other things. But yes, back to your pharma option, I'm reaching for a MIBO for those patients for sure. Yeah.
And then in office wise, a lot of our, thermo, those like LipiFlow, Tear Care, Ilux, MyBoflow, radio frequency,
Mm-hmm.
Tinsel, we've
Tinsel,
got
yeah.
some good options there.
Yeah, a lot of good options in that space to try to evacuate those glands. And I think great. I think everyone should have this procedure done, right? Like we all have probably some level of meibomian gland dysfunction. So yeah, those are some good, helpful, in-office treatments to help with that the evaporation. So speaking of like lids, we're talking about meibomian glands a lot. What about like lid hygiene, blepharitis issues? What do you look for when you're looking at that? Any particular way you're doing your slit lamp exam?
Definitely erythema, collarettes, but not, I mean, collarettes, yes, but also kind of that tinting at the base of the lashes, like, before it becomes a very like obvious collarette, and then telangiectasia. Those are like my big four. I feel like I'm always honing in
Yeah.
on. What
You
about
know, I
you?
I think that's the same, but there's also, you see typically female patient that has makeup on, but you can tell, right, if that makeup's old or new. Ooh, that's a conversation that should be had, like you can tell when that makeup is not new. Or sometimes the patient says, "Oh, I didn't put any makeup on for you today." And I'm like, "For real? There's makeup here. What are you do-" So, with the lid hygiene, it's sometimes just those conversations which, on how to remove the makeup properly, what to use to remove, makeup. Lining the water line can be so problematic for these poor meibomian glands are just trying to live without a liner on top of them. But that's where, I think handouts and that sort of patient education is helpful. But I do certainly the collarettes, the more you look for them, the more you see it. They are really, they're in a lot of places. So I see them pretty commonly. And that tenting or volcano sign, I forget the, technical term of that. Maybe there isn't one, but it's a pouting gland, like it's wanting to come out of that follicle almost. And that is, or misdirected lashes or lash loss. You can see that in a Demodex patient too. But they've released studies. It was Academy not this past year, but the year prior, on patient symptoms with that. And that is, the symptoms that patients are talking about is itching along the lash line. And this is different from your allergy patient who wants to itch more in that inner corner and like get their knuckle in there and just really kind of itch. This is like some scratching, the feeling to itch on that lash line. And then sometimes there's talk of extra crusting or gunk in the morning or history of styes. Have you ever had a stye before? Then this sometimes resonates with people. But are there any other questions you're asking or, clinical symptom things that patients will say to you for that?
Sometimes patients almost don't realize it if they've had it for a while. Like are genuinely those asymptomatic ones. So, and I think the lid aspect with ocular surface disease is such a big role. And so sometimes I feel like when patients aren't quite at the level, like they're not improving as quickly as I want them to. I mean, of course, we have neurodry and we can kind of chase that path, but I do go back and always relook at the lids and just make sure that I'm not really missing anything. But I like that you also call that like the loss of lashes and looking at those because it's, the obvious signs are like when it looks really inflamed and you've got those kind of dry crusties there. But really honing in a little bit further can really be helpful as well.
I think also like we can get busy in our clinic. I mean, I know sometimes I'll be in with a patient and then I'm like, oh gosh, did I write that patient before had a nevus? Like I can't remember. So my head is not always right in the game sometimes when I'm with that patient. So I think it could be very easy to blow past the lashes if they're not like overtly red or there's a ton of debris on it. Like you could easily, I think, miss this if you're not, actually in the moment in the exam and looking, doing a bumping up your mag even just to get a good look at that lash line to see if there is something that you're missing, because that will create a smoldering dry eye patient for you, and you will feel like your patient should be improving more than what they are. So yeah, that's a good call out. Sometimes I'll do that too, go back and look at the lashes, and or if someone didn't have makeup on that day. That has certainly happened to me. I had a patient with makeup. It didn't seem like anything other than just makeup. She came back without it, and I was like, "Oh my gosh, did we not talk about this? Like, how did I miss this?" But that can all matter for sure.
I've had that happen with a lot of my rosacea patients because they wear so much that you can't quite see,
Mm,
what's
mhm.
happening on their cheeks, and they have so much makeup on
Yeah.
those lids that it can be tough at times.
Yeah, that'll get you. And then what about, how are you telling patients to clean their lashes just in general?
Yeah, so if we're starting with kinda OTC, and I guess it depends on, like, how inflamed they are and if we're gonna do some other, kind of treatments, but if they have, any sort of collarettes, I am kind of thinking about maybe a tea tree oil based, unless it's rosacea. Sometimes then I'll kind of steer more for, kind of a different like a Zocufoam, like something like that, a little bit differently. But so for some of my patients that are really diligent or just have had this kind of chronic issue despite different in-office and different, pharma drops that we've prescribed, new lids, like, there's a kind of those at-home things that for some patients, they're really motivated to do that, and I think that that's okay. Hypochlorous acid, not really any direct impact on Demodex per se, but just overall, just lid face hygiene. I feel like hypochlorous acid in the beauty space, so not eye space, but in the beauty space is having a moment. It's like the new trend. You go to the gym, you come out, you spritz your face with hypochlorous acid. So I feel like patients are already a little bit kind of in tuned with that. So and even just raising awareness about lid hygiene, and whether you compare that to like the dental model or we shower every day, wash your lids and lashes. I think just awareness about that is good as well. What do you
Yeah.
do?
Yeah, I have a similar approach, except that if I see Demodex, I'm usually the access to Xdemvy now is so good where I am in Boston here. So, and the patients have been able to get it and at a good price point. And occasionally there is someone who tells me, some insane number, but for the most part, the access has been so much easier to get. The prior auths are very simple, so I'm usually just going right for Xdemvy. Just look, I'm like, can we just hammer this thing out of here so that we can get a better result? Like I'm not, but I'm with you. I'll do a tea tree oil wipe if needed. The other thing is, for patients that have lash extensions, I, it is I've yet to meet someone who has perfect looking lash extensions, right? Like it's inevitable that they're going to have stuff in there. And so for patients like that, I like a We Love Eyes foaming cleanser. They also have like a lash kit, like for lash extensions, where they have that special brush. And anyway, that they've got a little oil there too as well. So I like recommending that for patients with lash extension, because that'll get you. They can never get them clean. No fault to them. It just doesn't happen.
That's true. What about in-office treatments? Do you lean towards
Yeah, so I've got yeah, sometimes I'll do new lids in the office. Sometimes I'll take like some AcuSoft and cleanser and just literally manually go back and forth. I did this on this patient the other day. I posted on an Instagram story. I did a before and after. It is the most satisfying thing to like clean those lashes, but I did like a new lids on that particular patient. But yeah, BlephX is another, great option to try to remove some of that debris. Yeah, those are usually my go-to, and just patient education surrounding it, as you've mentioned.
Yeah, definitely. In my perfect world for a patient, meaning like access isn't an issue, like money isn't an issue, I would do like a Zest BluffX new lids, start them on like an XDenvy, and then talk about kind of the lid hygiene part of it.
Yeah,
And
perfect
so
world, love it.
yeah, just kinda hitting it from the three-step approach. Sometimes if they have a lot of rosacea, which of course ties in with the Demodex and even just overall the lid health, I'll even do like a 1% topical ivermectin, not on the lids, but cheeks and nose, and so for a lot of those really stubborn, like reoccurrent Demodex, and you've done Axivia a couple times, that has actually been pretty
Mhm.
helpful.
Oh, good. That's good. Yeah,
Yeah.
that's a good option.
So let's talk about tear volume.
Okay.
So, like, they're just not patients not making enough tears.
Yeah.
What do you look for?
So this one I'm looking at lacrimal lake is really the key thing that I'm looking at here. And I think once you really, I think with the approval of Trip Tier and Tiervaya, that now we're talking and thinking maybe more about the lacrimal lake than we were previously, unless it was really obvious that it was a scant lacrimal lake. But I think it's something that maybe now my eyes are looking at it a little bit more because I want to pay attention to that lacrimal lake because I now have ways that I can try to improve that lacrimal lake better. Um, so yeah, that is my main clinical symptom that I am looking at for that tear volume. What about you?
Yeah, same, but I like that
Mhm.
it doesn't take a lot of extra equipment. It's very quick to do. I'm actually a little shocked at how overall, the low tier volume is a little bit more common than I would have anticipated, and it
Totally agree.
yeah, and
Totally
it
agree.
until we had these new drops, I mean, I would look at it, of course, but not, like, totally hone in, and I'm like, "Man, there's a lot of opportunity here to improve it." It's not just these, kind of aqueous deficient patients.
Mhm.
It's a lot more common than I would have ever have expected.
Yeah. Are you doing, Schirmer testing, Jesselyn?
It kinda depends, not on the regular. Every once in a while, if we're doing something more systemic based or if we need it for, like, a prior auth kind of
Mm,
situation,
mhm.
but not on the daily, and that's really just more for, like, office efficiency.
Yeah, yeah, totally. I do it more not a ton as well, but I do realize or have come to realize that if you miss that aqueous deficient patient, oh, that's
I
really tough.
know.
You were gonna feel like you're not this patient's not getting better and you're not totally clear why that is. And so I think the with the advent of all of these new therapies, it is making us realize we have to make sure we're doing a great job at the diagnosis of dry eye. It is not just dry eye. It is the dry eye because of what exactly? Is it an aqueous deficient? Is it evaporative? Is it the glands that are issue? Is it a neuro component? So I think it's making us realize we got to be really good at that, and then we've got a targeted treatment, for that.
Definitely. You touched a little bit for low tier volume. We have, Trip Tier, Tyrvaya. Do you do anything else to
For the low tier volume patient, the other thing is if there is not inflammation, so often on this patient, I'm doing an MMP9 beforehand and, just obviously getting a good look at the patient, but I will put in plugs. So if I've got a patient that has low tier volume and is not inflamed, I usually do just the lower, depending on the case, but most commonly I just plug the bilateral lower lid puncta to try to raise that tier volume.
Yep, same. That's where Lacrophil for me, that and, depending on what type of plug, so we've got some good options there as well.
Yeah, yeah, absolutely. Yeah. And the other thing is a plug is billed to the patient's insurance too. So while that is an in-office treatment, it is not an out-of-pocket cost for the patient, depending on insurance and deductibles. Yeah.
Absolutely, absolutely.
All right, we're coming to it. How about the blink dynamics? Let's talk a little bit about that. How do you look at that, Jocelyn? What are you doing? Anything extra special you're doing for that?
I think the biggest thing for that is I'm looking at complete lid seal, so the Korbelacki test, which is huge. Take a transilluminator or, a pin light, something to even outside the slit lamp, just look for that sunset glow when you put that transilluminator on the lid. Shockingly, so many people do not have complete
So
lid
many people.
closure. And then,
Mhm.
of course, like common symptoms, like they wake up and their symptoms are worse in the morning, or, you see that inferior staining pattern. Those are all kind of big options to address it. And it's one of those things you can't forget because if that is there, you can do all of the other stuff, tackle evaporation, tackle inflammation, clean up the lid margin. But if that's still brewing beneath the surface, your patients are not going to get better. But treatment for that can sometimes be challenging because we've got this lid, and of course, surgery is an option, but surgery can be a little bit more of an invasive approach.
Mhm.
So, what are your go tos with that?
Well, for an incomplete lid seal patient, I start with this is my ladder. I go, all right, let's try some gels before you go to bed and or an ointment. And some people are not into the ointment. I personally like an ointment before bed, but not everybody's on board with that idea. So I say, okay, gel's here. If that's not moving the needle, we need an ointment. If that's not doing it, I've got sleep goggles. So honestly a big fan of the Blink Joy lid. What do they call it actually? Lid seal mask or lid hydration mask. That's what they call it. Blink Joy hydration mask. That is really easy to sleep with. There are certainly other sleep goggles that are out there. Eco has a sleep mask as well, but I think the Blink Joy is really comfortable. So I have that in my office and recommend that to patients. And then there is the Sleep Tight, Sleep Right tape. So I don't know if you've had patients, but I've had patients tell me they use a Glad peel and stick to like try to seal, their own eye. I'm like, oh God, we have something else you could use that is it is adhesive. It will not pull out your lashes. I myself have an incomplete lid seal and have used this tape and I enjoy it. It's almost like I just feel like there's almost wind on my eye when I think my eye is closed, but I know it's not totally closed. And I put that lid tape on and I'm like, oh, that's like lovely. So that could be a real game changer for patients. But it's nice I've got like my 4 options kind of in this little category of what I'm doing for my incomplete seal patients. Do you have any other things you're doing?
Those are the big ones, but I like to give my patients options as well because I think if you only recommend like only the eye tape, right, or only the eye seal, then sometimes my patients are like, all right, I need options because when I travel, I need this option. When I'm at home, I need this option. And so I think being able to just be really real with your patients, like let's try a couple. If it's not working, we'll kind of go from there. And then, of course, like in office treatments, we have the dynamic muscle stimulation. I haven't brought that in yet, so I don't have any like real feedback, but I do still think of that as for some of my patients, referring them out to possibly have that done to see if that can improve any of the blink dynamics that are there.
Other things to think about in blinking and lid, is these floppy eyelid syndrome patients. Being able to pull that lid really far away from the globe. That sometimes those patients, those lids evert while they're sleeping. So that's where I think a lid tape is very helpful. Um, but but yeah, the dynamic muscle stimulation, that is certainly an interesting aspect to try to tighten and improve the blink. I have a question for you that I do not have a good answer for, and I'm really hoping you're going to tell me a good one. What are you doing for these patients who are incomplete blinkers? This is the most unmet need, I think, is because we all know if we're staring at a screen, we number one don't blink as often and we also don't blink as fully. But how do you get someone to blink more? This is like breathing. You just are doing the blink you without thinking. But what do you do for those patients where you see these incomplete blinks?
Yeah, 2 things. One, just raise awareness that when they do think of it, blink. But this is where MIBO for me also kind of really shines in because it's hard to you can't constantly be thinking about full blink, full blink, full blink. And so I think for that, or if, you don't have access to that, like a thicker, ointment, just gel something. But MIBO, Optase and Tense drops are actually my like OTC kind of second go-to, but MIBO really does work in that scenario. What about
Yeah.
you?
Well, have you ever tried to use, presuming the eye is not inflamed, but do you ever try to use, or you're working on actively quieting inflammation, plugs to
Mhm.
try to just raise the
Yeah.
lake a little bit too? So
Mhm.
sometimes I will try that. But to be honest, I mean, I do the same thing. I'll grab MyBo. That is really probably where I end up feeling the most success. But even that, I'm like, we could be better here. Like that is one unmet need that I think the industry needs to work on.
Right. Innovators out there, unmet
Yeah,
need. Let's have a
unmet
product
need.
soon.
Yes, how do you deal with incomplete blinkers? Yeah, and then, I've talked with my oculoplastic surgeon about this, and sometimes they'll try to manipulate the lid, and they could, surgically manipulate the lid to try to improve that, but I don't know, Jessilyn, let's try to think of something, okay? We could
Let's
think
do
of the
this.
unmet need.
This could be our goal for 2026, bringing it back. New
Yes,
resolution.
yes, that's it.
Shark Tank for ocular surface. I love it. Okay,
All
good.
right, good. I think this is a good little rundown on kind of our algorithm. I think it's important to have your own. You may not like ours, or you might like some of ours and some of someone else's. And I think it's whatever you feel like is working well in your clinic and scientifically has been backed up. And I think there's so much out there and great options, but trying to not become overwhelmed by it and having your own treatment algorithm can really help make you feel like you're like, what am I doing for this patient? You already know. You already have an idea because you've already thought about your algorithm.
That's right. That's right. Well, and if you have anything new ideas, please feel free to hit us up on any of our social medias. We have a little kind of a schedule change to our To the Point podcast. So we are moving a little bit to a quarterly basis. So the next time you will see us or hear us, I guess, will be April. So if you don't, hear an episode drop next month, don't forget about us in April. We will be back for Q2 for another episode.
Yeah. All right. Nice to chat with you, Jessilin.
It's always so fun. And thanks to all of our listeners. We'll see you in April.